These are licensed doctor of physical therapists and occupational therapists who have asked me, well, what evidence really is there to be measuring blood pressure and heart rate? Like, these OBGYNs are criticizing us. And these professionals have not been able to stand on their feet and justify taking a vitals assessment on mothers who need them to. So I don't know that it's actually a privilege to be a rehab professional on this end of it. It's a privilege to have someone like you on our team, to have someone like Kelsey who didn't ask any questions. She came in, she was measuring vital signs the day she saw Jenna, right? Which was in the first week after birth. These are professionals that we need on our team, not us to be rehab professionals while we're in it, while we're patients. Yeah. Because in that moment, that was 12 o'clock in the morning, you know, and we have an OBGYN who's criticizing us. She asked, well, what do? You know, because we said, well, we're healthcare providers. So she's asking us, what do? We say we're physical therapists. And that just gives her more ammunition. She continues to criticize us. I mean, it was completely crazy to almost to be sent home and be told, rest.
Don't check your blood pressure.
Don't check your blood pressure.
Don't check it.
Walk 3 times a day for 10 minutes. She said that like to the T. And then just allow the physiology to do what it does. At 6 weeks, your uterus will go down, basically telling us to come back for our 6-week appointment and let us do our job. That was the last thing. Let us do our job. I think we're still not really clear as to why Jenna's BNP went up to 1650. That's just not clear. And we've had now 3 providers hint at that it might have been the fluid that Jenna was given, but you were the only one who continuously, you know, were really directing us to ask for BNP. I mean, that just has stood out to me during her whole postpartum journey. Like, relatively, her pregnancy was low risk.
Yeah, for sure.
Right. And then almost immediately postpartum is just when things really started to develop around that day 3, day 4, where we see a big fluid transfer. And then in Jenna's case, heart rate was dropping. And at one point, the ED physician, the main ED physician, not the obstetrics ED, they were ready to send us home in the obstetrics ED. But when Jenna finally told, you know, that doctor that she had been lying flat and getting chest pressure, the OB-ED said, well, that's not our area. The heart is not our area. Go down. In the main ED, they were looking at her EKG.
EKG, yeah.
And saying her heart rate was really low. And then mentioned what? What did you say?
Yeah, there were two gentlemen that were looking at the EKG kind of live, like as it was happening. And one of the guys said, like, oh, her heart rate's really low. And the guy said, yeah, you know, it's been low. I've noticed that. And the guy said, yeah, but in the 30s, like that's, you know, and so they were definitely showing concern. And I had known that it had dropped into the 30s. You know, I remember messaging you at one point saying, hey, I noticed overnight it got down to 39. And you had mentioned like, yeah, we expect your heart rate to drop back to baseline values, but not lower than baseline values. And so that was the first time that I think,
right,
you know,
like
even myself, I was kind of going, oh, wait, this doesn't seem like I'm going in the right direction.
Yeah. And with a blood pressure that, at its height reached 181 systolic, over 85, to me, it was just striking that not many providers were putting together, we need a BNP. You were. And I don't even think many rehab providers would have been putting that together we would know what's wrong with raising blood pressure and a declining heart rate, but I don't know that we would know exactly what was wrong to say, this is the direction that we should be going in, or the blood pressure medication or prescription you were given is not working fast enough. You're still trending in that wrong direction. We need to go to the ED. Like, it really took a lot of coaching from you to be like, we're just going to make a call on our own because our providers are not telling us to head to the ED and try to catch this thing before it gets any worse. And then that's when we discovered her BNP was up to 1650. Now, a 1650 would categorize someone as what?
Well, I mean, you're at really high risk for for really bad things happening. it's like there's so much damage being done, or like potential damage being done. But there's so much resistance, I guess, to or the heart is working really, really hard to do its job. I think that's the biggest thing. So the heart is working really, really hard to do its job, and it's not going to be able to sustain doing that job for much longer. And
Yeah.
so that's why the urgency of intervening, right? I think, Rebecca and Jenna, for people to really understand, if we could back up, I think they need to understand your labor process. Because when we look at risk factors for something happening post delivery, a big risk factor is how long you were in labor. People
Mm.
say how long was the second stage of labor, but in general, like how long you were in labor, how much fluid you received, all of that plays into the picture. Understanding that during pregnancy, we have this advantage, right? Our blood pressure is lower, the vessels are more relaxed. But after delivery, the blood vessels go back to their regular size. You lose that benefit. So when we think about blood pressure in general and what it is, we think about the amount of blood that's flowing through and the thickness of the blood, right? So we know our blood is thicker, and we know that the blood vessels are generally more relaxed, but there is more volume going through during pregnancy. So after delivery, if the volume stays elevated, the thickness is still elevated, and the volume now being elevated, not because you're pregnant, but because of how much fluid you got during labor and delivery, the blood vessels are still going to clamp down. They don't wait. I mean, it's not like they're like, oh, there's more fluid. Let's stay relaxed.
Mm.
That tone, that vascular tone returns. And so if it returns and now the blood vessel is more narrow, just like it was prior to you being pregnant, then that increased fluid will cause your blood pressure to increase, right? And so I think that when you look at the research and it talks about how after cesarean delivery, you're at a higher risk of heart complications, that's why we watch more closely. Because we know that the difference between a typical vaginal delivery and a surgical delivery is the amount of fluid that you get, because you need that extra fluid bolus before you get that epidural. You need it, you're getting it during labor. And then if it turns into a C-section, then you're getting more fluids so that your blood pressure doesn't drop, right? They want to make sure that they're counterbalancing what the epidural is going to do to your body. So you need more fluids. It's not like you don't need them. It's just your body had already received a bunch of fluids prior to that point. And so when we talk to labor and delivery nurses, that's what they always bring up. They know to watch more closely with cesareans because they get more fluids. They also know to watch more closely with people who labor over days, because you can imagine if you go in and it's 2 o'clock in the afternoon and you deliver at 6 o'clock in the afternoon, like a lot of our moms do, who just they wait for the contractions to be 3 minutes apart, right? The each contraction lasts a minute, that pattern lasts an hour. By the time they go in, they've only received fluids for 4 or 5 hours, if that. And so there is not this big worry about fluid overload, right? Because they just hadn't been there long enough. But if someone's been there for 3 days and as soon as they got there, they accepted the IV and they're getting fluids around the clock, it is a setup for something like this to happen. Not in a bad way. It's just they're receiving fluids because that's protocol, right? And so I think that that's what we really have to start looking at and thinking about. How long was the person in labor? Did they receive fluids the entire time? Did their planned vaginal delivery turn into a cesarean delivery? And then just considering the kidneys are working 50% harder, or at least much harder after delivery, for at least 2 weeks. So that same work that the kidneys had to do during pregnancy, still doing it 2 weeks following delivery. And that's just with getting rid of the regular fluids that come as a result of pregnancy, not thinking about how much is added on in the hospital and then how much is added on if there is a surgical delivery. And so for me, that is an automatic, this person is high risk. So we're watching closer, because you're not high risk because you're unhealthy. You're high risk because of the amount of fluids you received, right? And
Yeah.
so for me, my thought would have been towards fluid overload more than towards preeclampsia, even though you had higher blood pressure, right? Normally, I think the other thing to consider is, and that's why I asked you, lay on your back and see what your blood pressure is. Because if you're sitting up and your blood pressure is higher, the expectation is that if you lay down, it's going to be lower. And that's just basic. I mean, when we sit up, And we have that little dip, like if someone has orthostatic hypotension, like we see that. But in general, if someone's laying down, their blood pressure will be lower. They sit up, it's a little bit higher. They stand up, it's a little bit higher. They run or walk, and it's a little bit higher. So that's the trend that we expect. We
Mm.
do not expect you to lay down and your blood pressure will be high, right? Or that you feel that chest pressure. And so that's something else I think people should hear. Like when we hear chest pressure laying down, that's an automatic red flag for us. Fluids, because we think about it, if we're laying down, that gives fluid the prime opportunity to put pressure against the heart and for there to be resistance to pumping blood flow, right? To blood flowing. And so that in and of itself pointed me more towards fluid overload.
Mm.
And the thing about fluid overload is that there is a tipping point, right? Before it turns into heart failure. And we've seen it. Rebecca, we've talked to at least 3 or 4 people who now have LVADs because their fluid overload was ignored. And we, with monitoring, there's only been one other time that I've recommended a BMP to be taken. And in that case, the same thing happened. It was almost an identical situation. And except she went and got an ECG, like at an EKG at a med stop. And from there, they looked at it, sent her to the hospital. The cardiologist immediately put her on a medication and she was fine. But he told her, your heart would not have lasted like this for 2 more weeks. I would have given you 2 weeks at home like this and you would not have survived.
Wow.
And so, but we see people who they were dismissed. They're sent back home. 3 months later, they're told you have 5 years to live because your ejection fraction is now 15%.
Right.
And so it's
Wow.
important to not just, BNP, troponin, those are good to take initially, right? But then we have to follow up and see, like if something shows up there, then we have to know, was there damage done or did we catch it in time? And in your case, your ejection fraction is beautiful. Everything turned up great. We still want to follow up with a cardiologist because there was that fluid overload. But once they get rid of the fluid, here we are, right? Our body just needs help. And I know, Jenna, we talked about, if someone was limping or like they had an ankle sprain, as a physical therapist, we're automatically thinking, okay, let's give them a crutch. Let's maybe wrap their ankle. Maybe potentially they might need a boot. Let's say it was an Achilles tendon rupture. But if they're still limping, then we get them to a walker. We get them to a device that gives a little bit more support. And I think that's what's missing in the postpartum period is the support. What type of support does each mom need based on how she shows up to postpartum? And sometimes when you are an athlete, less support is given because the expectation is she'll bounce back. She'll be fine. Right. And I'm not saying that that's what was happening with you, but that is the danger of letting blood pressure creep up, of letting
I
heart
feel
rate
like
spike.
in the hospital, like definitely after the delivery, I could not count how many nurses we had that came in and talked about their own C-section experiences and how hard it was and how much pain they were in, how difficult it was to walk,
How swollen they were.
And for me, it wasn't, this sounds terrible, but it didn't feel like it was empathy. It felt like it was just normalization, right, of what Jenna was feeling, and praise that I was a physical therapist and partnering with her. But then I'm thinking, like, so we're given less support because this is a hospital that was actually listed on our directory as one that offers rehab to mothers after C-section, especially first time and unplanned. We didn't get any.
No one came.
And I was sleep deprived. The birth that, Eli was born at 2:58 in the morning. So by the time we're coming into the room around shift change, around 6:40, I think we came into the room. 7 o'clock was the shift change. So we had another nurse that came in to meet us after the first nurse, checked us in, asked us a whole bunch of questions. We had no sleep at this time. Even the night before, he started
sleep.
his heart rate started to drop at 1 o'clock in the morning. So Jenna was in labor for 32 hours. And so we had very little sleep because they were already waking us up at 1 o'clock in the morning the day before to change positions, to do something, because he was not tolerating labor at all after they induced her with the Dilapan rods. And so we were up since 1 o'clock the night before, then 2:58 the next day, he was born, then coming in, and then 7 o'clock, that's where the floodgates open. People just, one provider after another, pediatrician, you
Mhm.
know, just all these people. And it was just like, we're familiar with that, working in the hospital, working on the maternity unit, but it was just taken for granted. It wasn't any kind of support. And it wasn't even a question of whether or not she was an athlete. It was just, this is how they treat, you know, moms after C-section who they believe already have enough support.
Yeah, we also, just to add to that, we also had to ask for an abdominal binder. I don't think we would have been offered or given one I mean, that was the first thing Rebecca asked when when the nurse was introducing us to everything and
It's like,
checking
where's
us
the
in.
binder? It's been several hours.
Yeah. Um,
Would you not wrap a knee after you've replaced the joint? Like you wrap it with, like, what are we doing in surgical recovery after this major surgery? Like, I'm in there, and I've observed other C-sections before, but I was not observing that one. I was just observing what Jenna was feeling. I was with her as much as I could be the entire time, and I was just like, oh my gosh, like, just to be on that side of it. I'm like, it is so isolating. It's so cold. She was shivering uncontrollably,
mhm.
um, on little to no sleep. And I was just like, this is crazy. Like, this is crazy how we've normalized it. And we hadn't even calculated at that time how much fluid she actually received, because it just seemed like so much. As soon as we were um, admitted and the induction process began, the antibiotics started because her water had broken before she actually went into labor. So the fluid, every time his heart rate would drop, they would do another bolus. So it's really hard, like, until we get the records, which we don't have, it's really hard to say, goodness, how much fluid was entering into her venous system later to be transferred to her heart.
And Rebecca took a lot of videos during the labor process because, we also thought we were going to have a vaginal delivery. And so it was like, oh, let's document this. Let's look at all the positions Jenna's doing. Let's look at all the, kind of exercises that she's doing, stretches. And when we look back, or at least when I look back, I don't know if you feel this way too, Rebecca, but I don't even recognize the person I'm looking at because you can already see how swollen I am. It's everywhere. I mean, my legs don't look like my legs, my face, just everything about me looks so swollen. And I would say you were taking those about 24 hours after we had been already through labor. Because that was once we started Pitocin, you were taking a lot of videos. And so 24 hours worth of fluids. And the antibiotics that I was given because my waters had broken, and I'm fine to share this publicly, but I also tested positive for GBS. So it was another indication that they were kind of recommending antibiotics. But they do that every 4 hours. And to your point, Catherine, a lot of women who come in and maybe they need to be given antibiotics as well, they're maybe there for, like you shared a 4 hour story, but maybe up to 12, right? And for me, 32 hours. So every 4 hours over the course of 32 hours. So yeah, I do I follow along with the fluid overload theory, but yet we have not had one provider that's really explained that or even said that that's what they think happened. We've had some that say, well, maybe you had a pre-existing heart condition. I'm like, I didn't.
And then deny that the echocardiogram would have picked it up, because they said it was done too soon. So
Right.
the echocardiogram that was done in the ED when her BMP was 1650, they felt that was done too soon. It wouldn't have caught the changes to her heart. So they recommended the cardiology practice we're following up with does another one. But they're saying you must have had something else. And I'm just thinking, how many women are discounted who have been given fluid during labor over the course of several hours to days,
Mm-hmm.
are told that is something wrong with them,
Yeah.
you
Well,
know?
that it's really nice that you know your baseline, you know your health status, right? I think it's very smart to follow up with a cardiologist. I
Yeah.
also think that it is great to see that your body is just returning back to its baseline, right? All you needed was a little help. If they
That's
find
right.
something that's underlying or they find something when you go, okay, but you have to really think about it. I know for me, for people who don't know, they do say things like that, right? It's like,
Yeah.
oh, something was going on, as opposed to just looking at your medical picture and saying, this is what happened. And then let's look where you are now. You're back to your baseline of 48, 49 resting heart rate, right? And so
Hmm.
your heart's not working as hard anymore. When you think about the drop into the 30s, just anybody dropping into the 30s, that's not normal, right?
Right.
We are looking at somebody on a pacemaker. If we see that in practice, we're thinking something is wrong. For us on the dashboard, I know I have never seen a complete decline and someone passing, but that
Mm.
is the trend that you see. You see that their heart rate just keeps going down, and then eventually, if no intervention is done, then it'll just stop, right? And so the reason I think it's good for people to know their bodies ahead of time is so that you're not convinced that there was something wrong that you missed, right? Because even when we talked about your heart rate being in the 30s, and I just went back 2 years. I mean, you've been on the dashboard for 2 years and never, as healthy as you are, never had you dropped into the 30s.
Mm-mm.
And
Never.
so, right, you've always been in the 40s, sometimes in the 50s,
Hmm.
but mainly in the 40s. And so there was no precedent to it within your body. And there was also not a precedent to your blood pressure being that high. So we have to think, let's stop thinking something could have been wrong with her and just think, what is happening now? And the good thing is you did intervene soon enough that you don't have damage. For me, I didn't intervene soon enough. So weeks went by
Mm.
before I noticed that I was almost in nephrotic syndrome and my kidneys
Mm.
were scarred over. I mean, it was so bad, but it didn't have to get there for you because you had such a short time frame in which you all acted. And I think that's what people need to understand. I was told once by someone, an insurance provider, they said, it's hard to calculate how much you save the insurance company if you don't actually allow things to go wrong,
Right.
right? So do they know that something could have gone wrong, or would your body have resolved itself, right? Resolved it on its own. But I don't think it's worth the gamble, right?
I
Like
Mm-mm.
don't
it's not
understand that
worth
because we have that data already. I'm sorry. No, no, no,
Mhm.
no. We have that data already. We don't need every single mother to wait for problems to develop beyond their control, for them to develop chronic issues from birth complications to see how much we're saving or not saving
100%.
money or costing the system. We have that data already. We have morbidity statistics that now are what, 80% preventable
Mm.
in terms of death and maternal morbidity, long-term and short-term injury. We don't need more data on that. And you even said it. You were monitoring Jenna for 2 years prior to her delivery, right? We have data. We have data on how she was functioning. And this is a provider who's using no data
Mm.
to say that maybe this was a pre-existing condition.
Right.
Right.
Maybe you should do more data collection. Like these
Right.
providers are saying things to women and to mothers to make them feel that this is an individual
This is your
problem
fault.
when this is a systemic problem. You guys have data on what you're doing. Knowing that there's going to be a major fluid transfer after birth anyway, back into the maternal circulation system, and a C-section is going to add to that. Why push so many fluids? Why not give antibiotics orally? I mean, is that too hard? Like, I'm asking because I don't know. Just it
I
doesn't make
really,
sense to strain a venous system that's going to be, double or triple strained already. Why pre-strain a system that can't handle it? That just doesn't make sense to me.
I agree. I think that the problem is that it's, and so when someone goes in and says, I don't want IV fluid, they're looked at like something's wrong with them, right? or when they feel like they just want to manage when the fluid is given to them. We've had moms do that. Okay, I'll take the IV, you put the pep lock or whatever into my arm, but I don't want IVs fluids now. And so we've had people who they have been there, they get checked in at 4, they want to start the fluids at 5. And they don't until their body shows that they need it, and then they ask for it. So if they start to get dehydrated, if baby's heart tones start to change, then they've said, "Hey, I'll take fluids now." And for one of our moms, it was at 2 a.m. So she was there from 4 p.m. to 2 a.m. At 2 a.m., they told her, baby's heart tones are unreassuring. We probably need to have have you have a C-section. Sure, there was some underlying infection that we didn't see. And she was like, "No, it just doesn't sound right. Can I get some fluids? I'm probably just a little dehydrated." They did the fluids. Her baby came in an hour. And so can we, instead of using a protocol for fluids, individualize the protocol to the mom that's there, right?
Yeah.
I mean, as much as y'all hydrate, I'm like, Lord, you probably had a ton of fluid just from what you take in. It's not just what you drink, but what you eat. Like, y'all are so clean in the way that you treat your body that I just don't think everybody needs to be treated the same. And I think that's the problem. Because now that the statistic is out there that if you have a C-section, you have a higher risk of this or that, it's like everybody just takes it for granted that it's just going to happen or something bad could happen. But it's like, no, what you all have done, and I think it'll be so good for you to talk through what you did. I know you will with Kelsey, but just like how you got individualized care after. Your recovery does not look like everyone else who had a cesarean. You already talked about the abdominal binder, but there are other things that you did to make sure that your recovery didn't look like everybody else's. I do think that we should, though, talk about your blood pressure creep before we get into that, because when you are constantly told by a provider, wait till your blood pressure gets to 140 over 90, we'll intervene when you're at 140 over 90.
Yes.
This is a problem, right? You already had other signs that something was going on. If the average person, and I just don't even like to use this as an example because the average person is not at less than 120 over 80. I won't say the average, but I will say that there are a lot of people who do not reside in the 120 over 80 or less than 120 over 80 world, right?
Okay.
And yet we're told, well, wait till you get to 140 over 90 to intervene. So that person could potentially have been in the 120s over 70s, right? Or the 120s over 80s. And they get intervention at 140 over 90. So why is it that when you rest between 90 and 110, let's say, right at the top, and then between in the 60s and 70s at the bottom, why are you waiting till 140 over 90?
Exactly.
That's the other problem.
They treat everyone like they're the same.
They do.
It is. And that's a huge problem. And so when Rebecca and I were corresponding about that, 120 over 80 concerns me for you. Like that was already so if you look at the calculations, you look at the percentages from 120 to 140, then from 120 to 160, right? Because that's the range at the top. So if you're 140, they're like, oh, okay, some intervention should be done. 160, it's like, okay, this is an emergency, right? And so you look at the difference between 120 and 160. So then you have to think, well, what is that same difference for someone who rests at 90 to 100? At 128, we should be concerned, systolic, right? Yeah. I mean, it's your equivalent of 160. I mean, it's a percentage equivalent. And so we have to think, what is the percentage jump that concerns people, not what is the absolute value? Because if we wait for an athlete to get to 160 over 110, Jenna, you would not survive. And it's not that. I think the problem is that people think, well, she's athletic. She has more of a runway to failure, but it's not the case. Your body is used to operating one way. And so for you to get there is not good. We don't even want you close to the 140 over 90.
Right. Well, and I think, Catherine, what you're saying really resonates with both of us, because my blood pressure, I think it was on day 3, postpartum day 3, I want to say, where it was in the 120s, and it was over, I think, the upper 80s before we tried a very short walk. I mean, it was 4 minutes, which, my athletic background, that would be nothing, right? We didn't even make it to the mailbox. It was very, very short. And that is extremely concerning that for myself to not be able to go more than 4 minutes, I think was an indicator that something was already showing that I was going in a not great direction, because the protocol that they give anyone after a cesarean section is to walk 3 times a day, 10 minutes each. So 30 minutes total, right, throughout the day.
Right.
And that's given to just any person. And you would think, or I would think, I should be able to do that easily, given my background. And I couldn't even make it one time for 4 minutes. And so the blood pressure just kept creeping up from there. It was in the 120s over 90 after that walk, and it just continued to rise after that. So I completely agree that for me, even being in the 120s was, a red flag.
It was
But
a red, and that's right. You have to say it. Call it what it is, Jenna. Sometimes it's like it's a red flag. And as
yeah,
PTs, we see red flags, we stop. To me, a yellow flag would be closer to, I mean, so for your specific numbers, if we think of, let's say 100 over 60, just for average person listening, then once you get to 116, 117, I'm like, oh, what's going on, Jenna? You okay? Once you get to 128, it's like, Jenna, you got it. Whatever it is, you got to stop. But it doesn't sound like a high number to a regular.
right.
And
And to the
that's
providers. Yeah.
into providers. And so we have to start making people treat red flags like red flags. And I think that's what, when Rebecca and I talked on day 3, that's what we were saying. Like, it doesn't matter what people are telling you. We have to treat it like a red flag. And I beg people, look, okay, I know what you see in me. Please treat me like my blood pressure is 150 over 100 right now. What would you do then? Right. And if I ask them to do that and then they intervene and something goes wrong, I feel better that they at least intervened in a way, like they treated me with some sense of urgency, like they would somebody who was at 150 over 100. And then also, I think people really have to think what's happening to blood pressure in those first 2 weeks following delivery. And I know we've talked about this before, but really, the blood pressure management system is not the same. And so for that same 4-minute walk, your blood pressure would probably never have even elevated at all. But let's say for the average person, they're walking 30 minutes, their blood pressure is going to increase some. And then when they stop walking within 5 to 7 minutes, we expect that their blood pressure goes right back down to baseline. And you'll read some research articles, they're like, oh, check after 30 minutes, check after an hour. If you look at the National Institute of Health, you look at the World Health Organization, 5 to 6 minutes, your blood pressure should be back down to baseline, right?
Wow.
And so let's say that someone does that same walk, but it's in the first 2 weeks following delivery. We cannot expect that to happen. Or we have to decrease our level of activity, right? Like we have to adjust in some way because blood pressure goes up after delivery, just like normal, but the blood pressure management system is not always able to get it back down. That's not everybody, but that's why we check everybody. And when you said the 4-minute thing, I started laughing. I don't typically go in, but I reached out to Rebecca after the last birth that I attended in person. And they didn't send physical therapy in for the mom when they were getting her up. So I just went in and walked with her. And she said, well, Dr. Kent, how long do you expect me to walk? And I said, well, I just want to see how you're doing. We'll just see how far you can walk. And so we start walking and I start hearing her get short of breath at 3 minutes. And so I checked her heart rate and it was 139. And she's an athlete. And so in 3 minutes, it being 139, that's too much for you right now.
Yeah.
And so what we did was we talked through, well, how do we make sure that we're only doing things in 3-minute increments? And so we talked through that. 3 minutes, then rest, 3 minutes, then rest, 3 minutes, then rest. It should never be 10 minutes, 3 times a day. And you have no idea. Can you imagine if she kept walking for 10 minutes?
Mm-mm.
And that's why I set no expectations for moms. Their expectations will arise and continue to arise as they go. I heard someone say this the other day, and I thought it was so cool. They said, when you're driving in the fog, sometimes you can't see in front of you, like too far in front of you. But as you keep going, the way continues to show itself. Like each leg of your drive will continue to unveil itself. But you have to go slowly so that you're not driving through the fog blind. And I think that's what we need for postpartum care. We don't know what every mom is going to look like post-delivery. But we do know that every mom is going to look different and they deserve individualized care and attention. And yes, it is a blessing that you both are rehab providers, but everybody doesn't have that. and you shouldn't have to operate as a rehab provider when you're new moms. I mean, that's not our role. Our role is now motherhood. Our
Yeah.
focus is breastfeeding and bonding and skin to skin and not having to figure out our own rehab plan. And so I think that the fight, like we have to fight for not just rehab to be offered, because now you know it was not always offered,
Mhm.
but for rehab to be provided because we all deserve it.
I've been really thinking about this because I have heard ever since that first day that Jenna delivered how lucky we were that we're rehab providers.
Mm.
And it was in that moment in the obstetrics ED when we were going to be discharged by the triage
OB hospitalist.
OB hospitalist. And she was saying, just go home, rest, giving us a whole lecture. When I tell you it was the longest lecture on how after COVID, people started taking their own blood pressure, and this has been a real problem. Why are you checking your own blood pressure? I've really, really been thinking, was it lucky that we're rehab providers? Because I have been put in a position for the past 4 years, Catherine Sylvester, of asking or answering questions from rehab providers who had countered OBGYNs in hospitals, criticizing them for taking the blood pressure, taking heart rate, just like you did with that mom after 3 minutes, showing that her heart rate had gone to 139. These are licensed doctor of physical therapists and occupational therapists who have asked me, well, what evidence really is there to be measuring blood pressure and heart rate? Like these OBGYNs are criticizing us. And these professionals have not been able to stand on their feet and justify taking a vitals assessment on mothers who need them to. So I don't know that it's actually a privilege to be a rehab professional on this end of it. It's a privilege to have someone like you on our team, to have someone like Kelsey who didn't ask any questions. She came in, she was measuring vital signs the day she saw Jenna, right? Which was in the first week after birth. These are professionals that we need on our team, not us to be rehab professionals while we're in it, while we're patients.
Yeah.
Because in that moment, that was 12 o'clock in the morning, and we have an OBGYN who's criticizing us. She asked, well, what do you do? Because we said, well, we're healthcare providers. So she's asking us, what do? We say we're physical therapists. And that just gives her more fuel, more ammunition. She continues to criticize us. I mean, it was completely crazy to be sent home, almost to be sent home and be told, rest.
Don't check your blood pressure.
Don't check your blood pressure.
Don't check it.
Walk 3 times a day for 10 minutes. She said that like to the T. And then just allow the physiology to do what it does. At 6 weeks, your uterus will go down, basically telling us to come back for our 6-week appointment and let us do our job. That was the last thing. Let us do our job. And it took Jenna to say, when I lie down flat, I feel chest pressure, for her to say, we don't do that here. We don't do anything with the heart. Thank God she sent us to someone else. Like,
Yes.
thank God that she sent us to someone else. But I don't think the fact that we're healthcare providers and rehab professionals, because I understand now how easy it is to be bullied and be gaslighted and be thought, well, maybe I'm making this up. Maybe this is out of proportion. Maybe I'm wrong about this. Maybe that 130 over 90 was not that bad. Maybe that 170 over 94 was not that bad. And start second guessing yourself and watching someone almost deteriorate in front of your eyes. It's so easy to be in that position when you're sleep deprived. I don't count it that I'm a rehab professional and I'm doing the work that I'm doing as a privilege. I see it really, truly, that we need more of you on our team to fight for us, because when we're exhausted, we're like ultra runners. If we don't have our SAG team and our support team, we will flounder. We will deteriorate.
Yeah.
Even the greatest athletes in the world have a team.
Yeah.
Right? So I'm not saying it's a privilege to be who we are. Not at all. I need my team.
Yeah. Yeah. But you know what y'all did that a lot of people don't have the endurance to do? Is to still get the outcome that you wanted. I know when Rebecca, when I was like, we just need to get someone mobile to come to y'all. Like, she doesn't need to be getting dressed and getting out of the house and going to get these labs done, right? And so we're looking around who can come to you, who can get the BMP done, because if they don't order it, you can still pay for it. A lot of people cannot do that. A lot of people don't have those options. And it makes me so sad. Jenna, you have no idea how much I love and care for you. I was so scared for you.
Oh, Catherine.
I was so scared for you. But I knew that if something could be done, you guys would get it done. And that's why I was like, I don't want to reach out to Jenna. I just kept reaching out to Rebecca because I did not want to scare you.
Yeah.
But I was scared. And I think,
yeah, go ahead.
I think that we have to stop thinking, what if what we're doing, like, what if, I told Rebecca, the best thing that could happen is that we're completely wrong. That everything just resolves itself. But to me, the worst thing that can happen is that we don't like turn over every stone, right? And make sure that you're okay. Because you don't deserve to have to fight like this 4 days after you deliver your baby. But the reality is, we have seen people day 4. Rebecca posted about someone day 4 who died in her home because of this.
Oh.
And you think about it.
Yeah.
Fluid overload is not something that everybody's body can handle.
Yeah.
And we have to fight for those people who don't have access, who don't have time, who don't have family, who can't keep their babies with them when they go to the hospital. We have to fight for that. I think that we have to, as rehab professionals, start treating everybody like they're our family.
Yeah.
So that we don't overlook things that should be treated as red flags, whether we're in the hospital, in the home, it's somebody that we don't know. They deserve to have care. And so at the end of the day, I knew that you would get the care that you needed. But that's not everybody's story. That's not everybody's testimony. And then the reality is it's one test. It's a blood draw. They're drawing blood anyway. Why not just check it?
Exactly.
Why not
We
check
have people who
BNP? Like, why not even know that value? Someone said basal metabolic panel. Is that what you meant?
stop, Rebecca.
No, I can't make it up, Catherine. Like, I can't make it up. She was trying to correct me on what she thought I meant.
Yeah.
No, I meant BNP.
Yeah. You know, I think that it's really easy for most people who are postpartum, who may have even experienced what I was going through, to gloss over it and or to just think, well, this is normal. Everyone says how exhausted you are in the first few weeks. Most people aren't checking their blood pressure, so they wouldn't even know how high it's getting. And I just think that they may really not know. And they, a lot of women also that I've encountered, at least, will sleep in a recliner rather than in their bed early on, for multiple reasons. Maybe it's easier for them to transition in and out of it. Maybe it's because they're holding and breastfeeding their baby. It could be for a number of things. So they may not even know lying flat causes them symptoms. And that's the thing that I think I just couldn't agree with you more, Catherine, that having people on their team like you and what you and your team provides is life-saving.
It's exceptional.
It really is, because I just firmly believe that so many people would never know. And it would either result in possible mortality, right?
Mm-hmm.
Or these chronic problems that they then realize 6-12 weeks later, hey, I'm still not feeling great, but they probably convince themselves, everyone says the first 6 weeks are rough, right? That's what everyone's still telling us is give it the first 6 weeks. And the first 6 weeks are tough. I'm not here to deny that or say that that's not true, but there are certain symptoms and certain, physiological markers and signs that may mean that someone's having a more difficult time than even what is considered normal. So,
Yeah, I
Yeah, I
believe, I
agree.
wholeheartedly, and I told Jenna this, I believe that you saved her life. I believe that you and your team saved Jenna's life. And I can say that with that just wholehearted belief that for me, that's a fact because of the experience we had with the OBGYN in the emergency department. And I have to really reconcile with the fact that this is a provider who probably treats hundreds of women a year and told us to our face that I tell my patients to not check their blood pressure.
She said that for the first 6
And
weeks.
that's something I have to report.
Yeah.
I have to report. I'm as a healthcare provider and as a patient and as a family member of a patient of that hospital. I feel like it would actually be against my ethical principles, my commitment to do no harm as who I am, to not report that. And so many of our rehab professionals, because of our lower designation that we place on our degree, could come out of our face and say, well, Catherine was acting outside of her scope. You saved our life.
Yeah.
We would never, though, counter a physician that we think is acting within their scope who says something asinine like that, to not check your own blood pressure. And I tell my patients to not check their own blood pressure. When our midwives were saying, check it at least twice a day.
Yes.
And then she says to us in that same thread, in the same room while she was with us, well, I don't know what their training is. Right? Just putting down the training of midwives.
Yeah.
And we have to just reconcile with the fact that we are going to encounter providers that are like that. And we have two choices to make. We either turn away, we follow their advice and come what may, because it still lands on us had Jenna went home, right? Or we take a stand. In that moment, we decide, how can we get to the next best care? How can we get to the next person who could actually investigate what's going on? Finally, run the lab, BMP, finally do, an EKG, finally do a chest x-ray to see if there's a PE, a Doppler, all of that. Do all of the tests that you need to know to do. And then, thank God, give her an IV vasopressor that took her down, or a vasodilator that took her blood pressure down.
It was an intense.
It was very
blood
intense.
pressure med.
I mean, she was lightheaded for at least 24 hours after that, but they stopped the hypertension in its track when this OBGYN had no problem sending us home and just saying, take the medication. She was not going to intervene. And so we went to the professionals who would, and I'm asking people to really think about, you have two choices to make. If you're in a privileged position of being a healthcare professional, you really, you cannot allow other professionals to make you feel less than, to question your judgment, because for a moment I did, but you were somehow up at 2:00 in the morning texting us. Like, you were messaging us. And I say this on everything that I believe in and have fought for, is that I believe you saved Jenna's life.
Yeah.
Well, her life is worth saving. It's like everybody's life is worth saving. But we have to be there, right? We have to be present. It's not a 9 to 5 type of a thing. Because with birth, things don't happen in 9 to 5 ever, right?
Yeah.
We have to rethink that too. I think too, y'all, I think that for so long, blood pressure, heart rate, the way people sleep, like that has been, oh, well, if something goes wrong, then we intervene, right? When it really should be, let me use that number to guide my day. And that's really when I think about mist and what we do, that is what it is. If I wake up and my blood pressure is a little higher than normal, that helps me make different decisions for the day. And then if it gets to where it's approaching a red flag, then I'm going to get help. And I'm not going back home until I get help. Because there are things that you can do to positively impact your blood pressure. But if you're not taking it, you don't know if the amount that you're sleeping is okay, if the amount that you're moving is enough, if the amount that you're hydrating is helping. You have to have objective data before and after, right? So that you can make better decisions. And so I don't understand any provider who says don't take it. We know it's going to be different post delivery, just like we know it's going to be different during pregnancy. But that doesn't mean we don't take it. That means that we allow it to guide the decisions that we make. And I think that's where we're missing the link. When people say, oh gosh, her heart rate is so high, they think we're going to say, don't send her home. That's not what we're going to say. We're going to say, send her home with something that she can push the baby in. Make sure she has family members to be with her. Let's give her a plan so that she can conserve her energy instead of overdoing it. We're not saying to keep everybody in the hospital because their blood pressure goes up and their heart rate goes up, or because their heart rate goes down, or they're not getting enough sleep. We're saying, let's set them up for success. And I think that's the part that's missing. Yes, people are going to be scared if their blood pressure is high. They should be. Our blood pressure is not meant to be in the 180s, 170s, 160s. We're not meant to operate in that way. It should guide our decisions, and it should guide healthcare professionals' decisions. They should not wait until someone's blood pressure is completely out of control and they're coming in with symptoms before they intervene. Y'all, you talk about somebody ignore. Could not see out of my periphery. That was what sent me. That was what made me say, oh my God, I really have to get this blood pressure under control.
Wow.
You should not have to lose vision for that to happen. Right?
Yeah.
And so you having the symptoms that you had, they're scary, but they're behind you, right?
Yeah.
Like it's okay to be scared, but we have to then act. And when we take away the numbers, we take away people's ability to act. And as both of you have said, it either results in mortality immediately or morbidity down the line. And it's not just at 12 weeks, it's 10 years later. I saw a woman in chronic kidney failure at 27 years old from a birth, and she was 17. She had no idea that preeclampsia could impact her blood pressure in the way that it did her kidneys, her liver. She had no clue. At 27 on dialysis for the rest of whatever life you have left, it's not right. She did not know until I talked to her about it in the hospital.
Wow.
She never checked her blood pressure a day after she delivered her baby because she was told that delivery is the cure for preeclampsia. And that's exactly what I was told.
Yeah. Wow.
Preeclampsia. And I was like, I'm still checking because I don't know that. I don't know that it just all of a sudden now I'm out of the woods because my baby's here. Right. And it wasn't the case. I wasn't out of the woods. And so we never assume someone's out of the woods. We keep checking until they are.
Yeah. Yeah.
Thank you so much, Catherine.
Thank you, Catherine.
You're saving lives. You're saving lives. And you're building families.
Oh.
You're building, really.
Thank you.
Right?
We love you.
We love you.
I love y'all so much.
Eli loves you.
Oh, he's very thankful for you.
He's very thankful.
He's going to know so much about you.
Yes.
Y'all are the best. Y'all are the best. One thing I want to say, I always hate like bothering new moms. And I realize though that there's not always going to be a Rebecca, right? So like what I normally do is I go to the partner, I go to the spouse, and I'm like, hey. But when it's just a mom and she's by herself, it's even harder to bother her, to sync her watch, to take her blood pressure, right? But it's necessary. And I realize that even more as I continue to monitor. Ideally, there would be a way, just like blood pressure readings can sync automatically, for there to be some way that moms don't have to open their app, right?
Oh, that would be great.
No way, right? There's no way to do that, but bothering moms is sometimes necessary.
I agree. I totally agree. And I'm glad that you were texting me because I would sneak over to Jenna's side of the bed and get her cell phone, open the app and make sure she was syncing. If the blood pressures weren't in, I was putting them in and writing on the notes of like the position that we took it in. Because I think I don't consider it bothering. I don't know why.
Yeah, I would say that it's not a bother.
I'm the only one. I mean, Eli is going to have one mother who is loud and it seems like she's angry all the time and just yelling. That will be me. Well, and however that's perceived and coming across, it's just how people will perceive it and coming across, but he'll know it's out of love. Right. And so when I hear the word bother, I guess that was a little bit like I started ticking a little bit because I'm like, I know a pelvic health therapist, very prominent. She was president of the Academy of Pelvic Health Physical Therapy, who wrote in a response, it might have been on social media somewhere, but I think she used that term bothering. Like what, when I was talking about early rehab after birth in the hospital, someone coming in, checking on mom, doing an assessment, functionally, mentally, physically, all of that. And they use the word of bothering. And I'm like, that is your perception, but you're not asking the mother what she would want or what she would need. We never felt like anyone coming to our home, coming to our room for a good enough reason, right? That was actually going to help Jenna move better or feel better was a bother. We welcomed it. We were waiting for the rehab therapist to come that never came in the hospital that reported to us that they offer those services. That's not a bother. So, I mean, that word, I don't know why I hate it so much. And I think it's because we're projecting something and not asking. We're telling moms what they deserve to receive in terms of the recovery care, in terms of the surveillance, in terms of the support. We're telling them what they'll receive because we're perceiving they don't need anything more than just to care for a baby. And it's just like, no, we needed all the support. Like, ask us. You're not bothering us by telling us what you need to do your job to make sure that we're safe. So that the word choice, I feel like is coming from our judgment. It's not coming from the mother.
Right.
Right. She needs her community. She wants her support. And the family around her wants support too, because we have to also, get enough sleep, get enough nutrition, have our mental health intact so that we're good, for the long haul, of what this recovery journey looks like for her. So, I mean, to me, it's just, we have to stop making decisions on behalf of mothers when we've not asked their input.
Yeah, you're right.
Bother us, bother someone else too. Keep bothering people, Dr. Sylvester. You keep bothering people. We love you so much.
I would be surprised if anyone has ever said to you, "Can you stop bothering
Can
me?"
you stop bothering me?
Dr.
Can you stop
Sylvester,
trying to save
can you
my
stop?
life? Stop
That's
trying to save my life. Like, can you imagine?
I always feel it though. So I feel I'm like, Lord, but it's easy when there are two. And I'm so
Sure.
happy y'all have each other.
Sure. Yeah.
I really am. The
Oh,
way I
we are too.
like love each other. I'm like, oh my God.
Oh,
It is the sweetest thing.
yeah.
Thank you.
Thank you.
Okay, so tell me, how does it feel being moms? Tell me.
Oh, I mean, we love it. We absolutely love it. He is just the cutest, sweetest baby, and we just love everything that comes with it. Well, I say that with a grain of salt. We don't love sometimes when he's extremely fussy in the middle of the night and inconsolable sometimes. But he just has when he has the best like awake and alert moments where I swear he is just looking dead into your eyes and listening to every word that you say to him. Granted, he's only 2.5 weeks old, so not sure if that's really what's happening, but that's what it feels like. It feels like he is looking deep into your soul as you talk to him. Um, and that's really nice. Yeah.
That's so
What about
sweet.
you?
It's so many, someone actually, because of all of this, sent me a text and they were so surprised. I was surprised to receive their text, but I'm not surprised at all. But I'll be honest with you. Like, I think in terms of a bird's eye view, like a 30,000-foot view. And they sent me this text saying they were surprised that Jenna was treated that way because she was white.
Mm.
And obviously, we have a white child. And we chose a white donor because I wanted, a mixed child, but I wasn't able to get pregnant. We tried double, almost triple the times on me before going to Jenna, and then Jenna was able to get pregnant. And I was just thinking, like, when I think about Eli and I think about the conversations we have at night, because we're having full on conversations now. He's 19 days old and he'll be locked on.
He has got some good eyes.
I like it almost like the way that he is focused, whether I'm reading him stories and I'm just talking to him. I just wonder about the type of human being that God could have possibly blessed us with. Like he's made in his image, whether he was mixed or with another person's DNA or whether he's raised by me and listening and being attentive to everything that's going to be in his environment, is that we were blessed with a human being that was made in the image of God. And I think about that. Like I'll just stop and just look at him and he'll be locked on. I've just never seen such an intense look in a newborn
Yeah.
the way that he has. And I'm just incredibly just grateful that just to know how his story might turn out. I have no idea, the kind of individual he'll be, but he has parents that love him unconditionally.
Yeah. We're very excited of who he's going to become. We have no idea what that will be, but just to see the growth and to see what he's interested in, I think is going to be such a fun adventure. Because we talk about it all the time. We're like, is he going to like biking like you? Is he going to like hiking and camping? Well, he's going to come with us anyways, whether he likes it or not. Is he going to play instruments? Is he going to?
I've decided, the only thing that I'm really hoping for, because I really don't have any expectations, but I'm hoping that he develops his communication skills. That he's an excellent communicator, because I think that's the most important life skill that we can all have, is that he will discover his voice and he will be able to, you know, express his wants and his desires and his beliefs and whatever way he chooses to do that. I'm hopeful for that. And so I think just to continue to speak to him and see how his communication develops, that will be the most exciting thing for me.
That is so sweet. I think motherhood is just the greatest gift. When people are like, "Oh, I hope you got what you wanted for Christmas," I'm like, every day that I wake up to those children, like that's the
Oh,
great gift. And so for y'all, I'm just like, what a gift, a gift that was long awaited, right?
yes, yes.
And
Mhm.
now he's here
I know.
and surrounded by love. It is so sweet. And so it's just so nice to see y'all so
Yeah.
happy with the gift that oh my gosh. So I love that's my favorite question for new moms.
Yeah.
Is new parents, what is your favorite part? And
The
I can't
snuggles.
wait to see his the snuggles, right? The snuggles in the late night conversations.
Yeah. Yes. Yeah.
Thank y'all. I love y'all so much.
We
So
love
much. Thank you for taking
you.
time to do this. I was telling Rebecca, we never do these this early because I just like moms to focus on themselves. And
Mm.
it's really nice that y'all carved the time out 2.5 weeks after birth to talk about.
Yeah, well, the plan was for my parents, his grandparents, to watch him, but he decided he was hungry right at the start of this. So,
This was at 2 o'clock this morning. He uh will sleep when someone's holding him. He'll sleep the longest when someone's holding him. And that is just our 2 o'clock routine. We'll read stories. We'll go through a lot of his books around that time. He's wide awake. And I don't know. I always wonder if that's around just the time that because he was born at 2:58. Is that just something? Like
Oh,
he's like,
it's
it's my
possible.
birthday. Like, it's my birthday
Every
time.
day
What's wrong
is
with
my
y'all?
birthday.
Like,
yeah, this is when I came out.
like this is when
My
I
eyes
was
were
born. I'm
big.
here. Like, where's everybody? But like right now he's knocked out. Like it's time for him to be awake so we could sleep tonight. But that's not. We're on his time.
That's
We
right.
are on his
That's
time,
right.
and that's fine.
Yep.
But I could, yeah, yeah. I I can now relate that this is the greatest gift
Aw.
that
It,
anyone can ever have. I'm
Yeah.
completely
it
in
really
love.
is. Yeah.
All right. Thank you, Catherine.
Thank you, Catherine.
You are so welcome. Thank y'all. Y'all made my whole day.